So, good evening to all the participants, the panelists, and my guru and the main person who's here with us, Dr. Venkatesh Thuppil, to the entire team of Kaho Diagnostic Division. We are here to talk about one of the most special and close to my heart topic that we'll be discussing today, and that is going to be on the pre-examination variables that we talk in the laboratory medicine. But before we start, I told you that this is a topic which is very close to my heart. With the kind permission of Kaho, under the able leadership of Dr. Vijay Agarwal and Dr. Lalu Joseph, we thought of doing something in the diagnostic division category. And since this particular topic was quite close to me, I thought, like, let's introduce a series of sessions for all the participants throughout the country who can actually gain more knowledge on, and it helps them with resolving the problems which take place in the pre-examination part in the various scopes that they discuss on. So here we have with us the legend, the stalwart in the field of laboratory medicine, and my guru, Dr. Venkatesh Thuppil, who's with us. Dear friends, I wish to, though there is no need for an introduction, we are talking about the Dr. Venkatesh Thuppil, but for the newcomers, I would like to just present and talk about Dr. Venkatesh Thuppil. Dr. Venkatesh Thuppil is a Professor Emeritus of St. John Medical College, Bangalore. He's the CEO and the Director of Foundation of Quality India, that is FQI, and the Director of the National Reference Center for Lead Projects in India, that is NRCLPI. Dr. Venkatesh Thuppil is the current National Chairman of the Indian Society for Lead Awareness and Research, and he's also called the Lead Man of India, and was the Director of the project Lead Free of the George Foundation, which was instrumental in getting the unleaded petrol in India in March 2000. He served as the national chairman in getting the gazetted notification for defining the limits of lead contents in paints. Dr. Venkatesh is also a lead and a principal assessor for NABL and NABH under the Quality Council of India. He's also the advisor to Kaho and AHPI. Sir has served as an accreditation committee member for NABL, NABH, DAC in Dubai, and currently serving as the chairman of Laboratory Accreditation Board of Nepal. Dr. Venkatesh is the international. Dear friends, I wish to, though there is no need for an introduction, we are talking about the Dr. Venkatesh Thuppil, but for the newcomers, I would like to just present and talk about Dr. Venkatesh Thuppil. Dr. Venkatesh Thuppil is a Professor Emeritus of St. John Medical College, Bangalore. He's the CEO and the Director of Foundation of Quality India, that is FQI, and the Director of the National Reference Center for Lead Projects in India, that is NRCLPI. Dr. Venkatesh Thuppil is the current National Chairman of the Indian Society for Lead Awareness and Research, and he's also called the Lead Man of India, and was the Director of the project Lead Free of the George Foundation, which was instrumental in getting the unleaded petrol in India in March 2000. He served as the national chairman in getting the gazetted notification for defining the limits of lead contents in paints. Dr. Venkatesh is also a lead and a principal assessor for NABL and NABH under the Quality Council of India. He's also the advisor to Kaho and AHPI. Sir has served as an accreditation committee member for NABL, NABH, DAC in Dubai, and currently serving as the chairman of Laboratory Accreditation Board of Nepal. Dr. Venkatesh is the international the Chronic Hypoxia Society and a visiting professor of the Zubeda University at Bolivia and visiting scholar for the University of Cincinnati at USA. He's the recipient of international awards for science, truth and honor, prestigious Aryabhat Award, apart from the Lifetime Achievement Award from Kaho. He's also technical advisor to UNIGO and WHO. He has published over 350 scientific papers in the peer-reviewed journal. And here I welcome Dr. Venkatesh Thuppil to please share all his wonderful thoughts and help all the newcomers and the people in the field of diagnostic medicine with his expert advice. Over to you, Dr. Venkatesh. Thank you so much, sir.
Thanks to you, Santwana. Thanks to you, Aparna, and my friends who are here today. I am honored to be here to share my views and thoughts about this pre-examination processes and variables involved in this section, particularly with reference to diagnostics and management. When I say pre-examination processes, it's a very vast area. In fact, Harvard study way back in 2007 has very clearly indicated that in the US alone, the number of errors which have occurred in the laboratory, diagnostic laboratory, when they're calculated, over 62% were found in the pre-examination processes only. Why is that? We are worried about two things. One is, what are all the variables in the field of diagnostics in the pre-examination processes? And how do we manage them? You see, this is a double-edged sword, I tell you, because when we talk about the processes, you see, we know, all of us who have assembled here, we either represent the accredited testing diagnostic laboratories, or we are going in for accreditation. As per the requirement of an international standard, ISO 15189 of 2012, which means that is the latest version we have till we get a new version in the month of November 2022. That will be the 4th edition. The first edition came in 2003, second edition came in 2007. The third edition was released on the 1st November 2012. Now, prior to 2003, when we did not have the medical laboratory requirements for quality and competence, we were depending upon the mother document, the ISO 17025. That was the document. In that ISO 17025 document, which was generic in nature for all testing and calibration of laboratories, the terminology which was used was pre-analytical, analytical, post-analytical. Now, when the medical people like you and me got together, we said, we are not analyzing any patient samples. We are only examining the patient sample. The word analytical was replaced by examination way back in 1993. Henceforth, after 1993, we are not supposed to use the word analytical. And hence, please permit me, I'm using what standard has asked us to use, that pre-examination, examination, post-examination, and the actual true examination depends by the clinician on the laboratory diagnosis. Therefore, the title which is given to me, I'm very happy, accept it. Pre-examination processes, it's not a single process. There are a number of processes. So 8 processes are involved here. Please remember, there are 8 processes. I'll tell you which are these 8. In these 8 processes, there are 44 variables. I have counted each one of them. I'm going to show you. There are 44 variables in the pre-examination processes when we consider a general laboratory, diagnostic laboratory, wherein I have not included the imaging laboratory. I have not included medical physics. I have not included neurophysiology laboratory. There are, apart from that, in the routine diagnostic laboratory, like pathology, clinical chemistry, microbiology, molecular diagnostics, histocyto, various sections of this, there are minimal 44 variables. Maybe in some section, there could be more than 44 variables that you will be able to. Dr. Zubair will be able to find out from his discipline. Dr. Saurav will be able to find out from his discipline. Dr. Aparna knows that in her pathology section, there are more variables than 44. Now, what I would like to cover today is what is required as per the international standard with reference to pre-examination processes. I'm not going to deviate from this standard because all are guided by this ISO 15189 of 2012. When you look at this ISO 15189 2012, there is one important requirement. I think you must make a note. That is, there's a requirement of documentation. No other section demands so much of documentation, I tell you, in the laboratory work. It is the pre-examination processes which requires a lot of documentation. Therefore, documented procedures are required apart from information for pre-examination activities. Now, what is that information for pre-examination activities? For proper identification, proper processing, proper usage, proper disposal of the biological materials which are subjected to examination. And it is required to ensure this particular section 5.4 in the ISO 15189, this particular section I would consider as a foundation for any good laboratory practices, gives a strong foundation. It is required to ensure validity of examination results. There are two clauses in ISO 15189 where we use these two clauses to validate examination results. One is 5.4, another is 5.6. See, when you buy an equipment, that equipment must be validated by the manufacturer. When you buy the kit from IVD manufacturer must validate it. What is that we as the user should do? Verify. Therefore, ISO 15189 very clearly mentioned whatever service is provided by anybody, instrument manufacturer, IVD providers, they have to validate. Whomsoever uses this, consumer, end user, must verify. Similarly, the laboratory is a manufacturing company. You are manufacturing the patient results. You are getting the patient results from various processes. And that has to be validated by the laboratory people like you and me. Therefore, 5.4, the pre-examination requirement, it clearly says all the 44 requirements. I'm going to count one by one when I tell you in next 1.5 hours. They are all the validation processes. And who will verify what result you are going to generate in the microbiology or pathology or in the molecular diagnostic? It is verified by the user, that is the clinician. Therefore, if one side of the laboratory diagnosis is validation by the laboratory itself, the other side of the coin to give value to the patient is the verification by the clinician. If these two gel, I tell you, if validation and verification agree with each other, then only the patient is not at risk. In fact, in the next version of ISO 15189 of 2022, there will be what is called risk assessment in every class. However, in ISO 15189 of 2022, under one of the processes, the risk assessment focuses on the pre-examination activities. We don't call processes, there we call it as activities. With this as the background, please remember, there are 8 kinds of information and requests in this class, 44 variables which can vary. When I say variable, wherever there's a variable, there's an uncertainty. We may think measurement uncertainty will come only in the examination phase. In fact, even here, there's an uncertainty. Uncertainty of identification of the patient, uncertainty of the sample, uncertainty of transfer, uncertainty is everywhere. Wherever there is an uncertainty, you know, there is no guarantee. Wherever there is no guarantee, there is a risk. Here, before I actually go into the details, I will tell you 2 more terminologies. We usually use the word non-conformity. When we are supposed to follow something, if we don't follow, it becomes a non-conformity. Non-fulfillment of the requirement as per the standard statement, if it's non-fulfilled, it's a non-conformity. But remember, if you have non-fulfilled, you can fulfill it. That's called continual improvement. Therefore, there's an opportunity for improvement, which is called non-conformity in the entire, but number of non-conformity one can find is maximum in this particular pre-examination processes. It is not a single process, number of processes. At the same time, there is what is called a risk or error. What is an error? An error is what you are supposed to do. If you don't do, it is a non-conformity. What you are not supposed to do, if you do it, it becomes an error. Non-conformity can be corrected, error cannot be corrected and erased. Please remember this. Keeping this in mind, let me go to a very important thing on importance of documentation. I am covering only pre-examination processes. Now here, the diagnostic laboratory has to have a lot of information for pre-examination activities. I told you there are 8 activities. To ensure the validity of the exam results. See how beautifully the standard says you have to validate what results, where at the pre-exam level itself. For this, you have to have a documented procedure. Friends, please remember the documented procedures, what you are going to have in the pre-examination section of your laboratory in any area of operation is only towards validating your end result. This is first requirement, general requirement. Then let us go to some of the variables. I told you 44 variables. You can start counting now onwards. The medical diagnostic laboratory or laboratories. Why do I say laboratories? Because the title of ISO 15189 is medical laboratories, not laboratory. Requirements, not requirement. For 2 things, quality and competence. Quality of all resources. Who is handling all the quality resources? Competent people. Therefore, ISO 15189 talks only about the quality of resources handled by competent people like you. Now, quality. Quality definition, you all know, I don't have to repeat. Doing the right thing at right time for the right purpose. Whereas competency is combination of 3 things. Appropriate qualification. For a pathologist, pathology qualification. Microbiologist, microbiology qualification. Biochemist, biochemistry related qualification. Plus adequate training in different activities. Because during the degree, diploma or postgraduate courses, people are not trained in all equipment, all methodologies. That's why they need training even after they get the degree. Adequate training, appropriate training. Following that, then what one requires? Experience. Therefore, the combination of qualification plus training plus experience will make the person competent to use all the resources. How many? 8 of them. 8 resources in order to fulfill the requirements of the pre-examination processes. Therefore, for this, laboratory shall have information available for patients and users of the laboratory services. When we talk about instructions, information for patients and users, there is one important thing, information. What is information? Is a knowledge to be given. This knowledge shall include as appropriate some of these variables. 15 variables under this section. Because title given to me my colleagues is variables. That's why I focus on variables now. Now, if the information given to the patient, let us start from home collection or for walk-in patient, they should know where to come, which branch they should come, which address they should come, the location of the laboratory. If it's confusing, then there is an error. They may not be able to come in time. Instead of 1.5 hours was 8 hours fasting, they may take 12 hours fasting. Instead of 1.5 hours postprandial, they may come up to 3 hours. Therefore, location of the laboratory should be communicated. There should be evidence for that. This is one variable. I tell you, this is 1 out of 5 patients have complained that they were not able to reach on time because they did not have the proper instructions for the location of the laboratory. Number 2, second variable. Types of clinical services offered by the laboratory, including examinations referred to other laboratories. Unfortunately, the ISO 15189 system have not understood Indian scenario. In Indian scenario, it is not the referral laboratory. You all know there is what is called B2B. You are working in a laboratory, you know, half the number of tests in the menu is referred to some other laboratory which does it at lower price than what you quote. It's called B2B. Now, types of clinical services offered by the laboratory, not sent to another laboratory. But here it says examination referred to the other laboratories, which is called referral laboratory. That comes under different class altogether. But unfortunately, majority of the tests in our country are going from collection centers to the laboratory or from the laboratory to back-to-back kind of laboratory service. This is another variable. The third variable is opening hours of the laboratory. This opening, why do we consider this as a variable? I had been to a laboratory, I saw the board, it's open from morning 8 till evening 8. I went there at 8 o'clock, it was closed. 9, it was closed. 10:30 only they opened. When I asked, sir, these days we are not getting samples. Some excuse. Now, this is another variable which causes some kind of uncomfort, untimely collection of samples from the patients that will lead to erroneous results. I don't say wrong results, some kind of erroneous results. Another variable, the examinations offered by the laboratory, including as appropriate, information concerning sample required, primary sample volumes. Primary sample here refers to the sample collected from anatomical site. Here there is one variable. Is it collected from right hand or left hand? Is it collected from the IV line? Is it collected? Well, how is it collected? Is tissue collected from the OT table? Is tissue collected after that? Now, special precautions for each, it depends upon department wise. You are all experts in your own department. I am not very familiar with your department. Please kindly interpret this specific special precautions from your department. There are many more variables there under this. And turnaround time. This is, somebody asked me, sir, what is turnaround time? I said, what do you think? The person said, from the time the sample is received at our reception till the result is released at the reception is called our turnaround time. I said, courier boy brings the sample. Sample was collected in Varanasi. It has come to your laboratory after 2 days. Now, do you take the turnaround time from the sample received, from the time the sample received in your laboratory till the result was released? He said, yes. But true turnaround time, I tell you, the true turnaround time, absolute turnaround time, from the time doctor requests for the investigation till the result reaches the doctor's hand. From the time the doctor suspects that this is the probable condition till he gets the result to confirm that or not, that is the turnaround time. That turnaround time consists of number of sub-turnaround times. One of them is at what time doctor asked for the test, what time the concerned phlebotomist or a nurse collected the sample, that is one turnaround time. It may vary, that's one variable. After the sample is collected, when it was picked up or when it was sent through the pneumatic tube, pneumatic system, there's another turnaround time. From that time, how much time it took to reach the lab, whether 2 minutes or 2 hours, there's another turnaround time. After it reached the lab reception, how long it was lying on the receptionist table, when did it reach the concerned operator, that's another turnaround. There are number of turnaround times. Therefore, when you talk about turnaround time, which may also be provided in general categories or for group of examinations, which again depends upon your expertise. Now, coming to the biological reference intervals. Unfortunately, we do not have biological reference intervals for our Indian population for most of the parameters. Though we are the largest populated country, we have not established this. Why is that? Because this was not on priority. We take shortcuts. We borrowed the biological reference intervals from UK, USA, Australia, and other places where there are genetic variabilities, so many variabilities, nutritional variability, climatic variability. Now, this biological intervals, reference interval, ICMR spent huge money way back in 1980s. Huge money with multicentric study to establish what is the range, albumin, globulin range in Indian population, what is hemoglobin range in Indian population. Because of diversity we have with the nutrition, with various different kinds of genetic. Now, we were not able to establish biological reference interval. I had made a suggestion way back that India started a lot of clinical trials where volunteers used to go to some of these pharmaceuticals to donate, to give blood without any medication. And then they used to get selected for clinical trials for new drugs. That particular population, we could have used all youngsters, male, thousands and thousands of them. They went through LFT, RFT. I tell you, that data could have been a wonderful data for establishing biological reference intervals in our population, which was not done. All has gone into the drain under one particular pretext, that it's confidential. Of course, the clinical decision value, again, is much more complicated than establishing biological reference intervals. You have to have a lot of patients in various levels of their sickness, from where you have to collect samples, analyze, and find out at what level, critical level, the clinical intervention is required, that leading to clinical decision value. This is another variable. Coming to another variable is examination request form. This word test request form should be erased. There is no more TRF. Nowhere in the standard the word test is used. You go through the standard tonight if you have a copy. The word test is not used anywhere in ISO 15189. It is the examination. Therefore, instructions to the clinicians, instructions to paramedicals, instruction to the nursing staff, instruction to the patient on filling up the request form. Examination request, not collecting sample here, filling up. There are so many variables there. In each request form, there are 22 variables. Anything can go vary. Earlier, we used to ask for age. We used to ask for gender. Now, age is not important. Date of birth is important. DOB is important. Because age, 2 years ago, that girl was 18 years. Today also she is 18 years. 2 years later, she will say 18 years. She will say 18 years plus few months. But what we need is the date of birth, which will give the exact age of that person. Therefore, instructions for not only completion of the request form, instructions for preparing the request form, what all it should contain is another topic. There are many variables there. It is in the pre-examination phase. Pre-examination variables, instructions for preparation of the patient. Now, before the needle goes into the vein, before the catheter goes into the urethra, now for a bedridden patient, now some instructions should be given to the patient. What instructions? It varies again, discipline to discipline, varies from pathology to microbiology, microbiology to biochemistry. That is another variable, set of variables. There are 6 variables there. Then comes the instructions for patient collected samples. What is the sample patient collect? There are only 2 samples or 3 maximum. Saliva, they might collect, sweat they may collect, stool they may collect, urine they may collect. Now, precaution should be given, instruction should be given to the patient collected sample, because I had a very funny experience of giving one bottle to a patient who was for home collection of urine for 24 hours, 5-hydroxyindoleacetic acid. The patient had the problem because a female patient to pass the urine into the narrow mouth bottle. People had not realized that. And when it was given to a male old man with the prostate enlargement, except into the proper hole in that bottle, the urine went all around. No funnel was provided. There are practical problems. Therefore, instructions for patient collected sample, how it should be collected. Another incident happened when the patient collected urine sample for 24 hours, reached the lab. The person, the son or grandson of the patient, started shouting at the technician, saying that he had big problem with his mother or grandmother, because he had taken the bottle from the laboratory with somebody's urine. Our laboratory had not mentioned that it is the preservative which was kept in that bottle. And the lady at the home said, why do you bring somebody's urine from the hospital? This was another confusion. Therefore, instructions for patient collected samples is another variable which may lead to discarding that preservative from the bottle for urine collection. And washing that urine bottle, urine container with tap water to infect that, when the urine had to be collected in a sterile condition, unless if instructions are not given. That's another variable. Instructions for transportation of samples, including any special handling needs. Here, any special handling, not just handling needs is hazard, logo, etc. Is special handling to maintain the environmental in the box, environmental outside the box, like temperature, humidity, radiation, etc. Instructions. Now, these are all the information for the patients and users. And there are, I told you, 15 informations. And the next one, any requirements for patient consent. Now, for all invasive procedures, we require informed consent. For general routine exam, we require patient consent. Patient consent is considered if the patient himself or herself present themselves at the time of paying the money or in the laboratory. That means there is a consent. If patient comes with the examination request form or ERF, not a TRF, that itself is a consent to disclose clinical information, family history to relevant healthcare professional, which is invariably not done. I tell you, 80 to 85% of patients who come and present themselves, no laboratory staff will ask the family history, relevant healthcare history, travel history. These days, because of COVID, it has taught us some lesson. We have considered that some of these variables also to be captured. Then the laboratory's set of rules called criteria. Set of rules is developed by the laboratory, not copied from some other laboratory. Unfortunately, laboratories are going in for accreditation. What they do, they go to a consultant. Consultant has a template of what they have successfully implemented in another laboratory, which got accreditation. The same template is used in this laboratory, but that may not work. Therefore, laboratories set of rules, laboratories criteria, not some other laboratories criteria for accepting and rejecting samples. This is something most of the laboratories copy from textbooks, journals from some other laboratory. But I tell you, this is a variable specific to the laboratory. List of factors. List, not one, list of factors. There are 18 factors known to significantly affects the performance of the examination or the interpretation of the result, because this comes under validation. Because these set of 18 factors are the factors, pre-validation factors. In fact, 2 hours is not enough for anybody to cover this topic. It requires whole day. I'm just, I am trying to cut short. Please pardon me for that. Okay, this is validation requirement. The pre-examination processes considering 18 variables for the which affects the performance of exam. That means 5.4 is linked to 5.5. 5.5 is examination processes, whereas we are discussing pre-examination process. These 18 factors overlap between pre-exam and examination. Coming to availability of clinical advice. Now, proper clinical advice on ordering of exam and on interpretation of exam. This is 2 ends are meeting here. One is ordering examinations, then interpreting examination results. Look at this. These two, who will do this? Ordering is done by the clinician. Interpretation is given by the laboratory person. And sometimes this interpretation is not there because the clinician has not given sufficient information, clinical information. This is one complaint in every laboratory. We are not getting cooperation from the clinicians. That's what laboratory head says. Clinician says, I don't trust that laboratory head. Laboratory head doesn't provide the interpretation of what I want. Triple test is done, no interpretation given. Now, this is another variability. Variability here in terms of cooperation, coordination, not with respect to the scientific data. The laboratory's policy on protection of personal information, I tell you, this is, you know what happened to one of the chain of laboratories in India 2 years ago. 36,000 patients' results were leaked out in Australia. How it went, nobody knew. I don't want to mention the name of this chain of laboratories. Australia, it came in WikiLeaks and many other social media. The laboratory's complaints procedure. The complaint procedure, you see, complaint is a gift. I consider it is a very powerful variable, the complaint itself, which can reset the laboratory operation for a better performance. This is A to N, 14, I think 15, A to N, 15 variables in the information to patients and users or the variables. Laboratory shell here is a mandatory requirement. It's a requirement. Nobody can escape from that unless they don't have pre-examination phase. Mandatory requirement. Whereas should is an optional. Choice is given. Whereas may says you may not, may do that. Therefore, shall, should, and may are used in the standard. Wherever you have the mandatory requirement for variables, you find the word shall. Laboratory shall have information available in the form of document for patients and users that includes an explanation of clinical procedure to be performed to enable informed consent, like the lumbar puncture, the paracentesis, thoracentesis, cisternal puncture, synovial extraction. Importance of provision of patient and family information where relevant, true information. Example, for interpreting genetic exam results, we don't get the correct information. There's a lot of variability, especially if there is some genetic disorder in the family, like Parkinsonism, MND, ALS. They don't disclose that my uncle had motor neuron disease. They will not disclose, thing with the fear that their daughter may not get married to somebody. Therefore, this variability is very difficult to evaluate unless you have a counselor and a social scientist to intervene, which shall be explained to the patients and users, saying that benefits of disclosing this information, this important variable, how it is going to bring about the assurance of better future life for others in the family. Okay, coming to the request form information. What request form? Can somebody tell me? What request form? Examination request form, not the test request form. The examination request form. As I told you, the word test does not appear anywhere in the standard from 4.1.1.1 to 5.10.3G. Nowhere it comes. It's the examination. The examination request form, or it is, when you say form, it's hard copy. Yeah, an electronic equivalent, that's on the computer, shall allow space for inclusion of, but not limited to the following. That means, in addition to that, many other information could be there. There are only 7 given here. What are those 7? A, B, C, D, E, F, G. Let us see what are they. It is the information. Information is the power. Information leads to knowledge. Knowledge leads to discovery. Discovery leads to invention. Invention leads to innovation. Innovated laboratory. Innovation is the ultimate goal of our CAHO laboratories, I tell you. Now, patient identification, including the gender. We don't use the word sex. Date of birth. We don't use the age. Location of the patient, which is dynamic in nature. Contact details of the patient. Means care under who is the caregiver, who is the caretaker. Caregiver is the clinician, caretaker is the family member, and a unique identifier. Who can identify that patient with physical mark? This note says unique identification includes alpha and or numerical identifiers such as hospital number, personal health number, blah blah blah. All that. All these are variables again. These are all pre-examination variables, which can misguide us if it is not properly captured. B, name or other unique identifier of of clinician, healthcare provider, other personnel legally authorized to request examination. When I say legally authorized, there should be written document saying that who can request for the examination with the appropriate, adequate authority, qualification, knowledge, must be competent. Competent person or legally authorized to request exam. Today, like go to the pharmacy counter, order any antibiotic, they will sell, you take it. In laboratory, people walk in, ask for many tests, but that should be curbed. It says very clearly, only the person legally authorized to request exam. Self, it cannot be legal many times. In fact, people come, they say, this is my urine, I want this test to be done. It is not that person's urine, somebody's urine. Or because of certain family problems and court cases, they want to pull down some. That's why legal world has come. Use medical information. Who can use medical information along with the destination for the report and contact details? These are variables. Type of primary sample. Primary sample is called sample collected anatomical site for in vitro diagnostics only, not for in vivo diagnostics. ISO 15189 and under the preface in section 4, it's very clearly mentioned that ISO shall not take any responsibility for violating any of the patent rights in the entire standard, which is detailed in the bibliography of this ISO 15189. In that bibliography, reference number 17 to reference number 48 are very, very crucial. 17 to 48, that reference number, they are all CLSI guidelines. If you are using those CLSI guidelines and indicate these guidelines are being practiced in the laboratory, they can come and sue you in the court because they're all chargeable. You have not paid any money. ISO will not take any responsibility. That's my legal requirement. Examinations requested. It is not one examination. Examinations requested. Some of them are done in-house, some of them are done outside. There is a variability there. And E talks about a clinically relevant information about the patient, which is uncertain. I tell you, no clinician on this earth is a Brahma. He doesn't have the 100% knowledge about that disease. I tell you, I'm very happy to tell you that no clinician can give 100% guarantee about their diagnosis for many of the conditions. I'm very happy because there is an opportunity for it. This is a very powerful variable. Now, clinically relevant information about the patient and the examination request for examination performance by the laboratory experts, competent people, and results interpretation purposes. Unfortunately, that clinical information is not available and laboratory is unable to process or provide the full report. Report is complete detail, including clinical information, pre-examination information, and also the post-examination data. Result is only one data. Result is only part of the report. The note says information needed for examination performances in the laboratory and results interpretation by the head of the laboratory, experts in the laboratory, may include, it doesn't say shall include, may or may not, patient's ancestry. When we talk about diabetes, we first ask, is your parents diabetic, grandparent diabetics? Family history, like syncope, is there a family history? Travel history. Today, we are all very familiar with the viruses going around. Your exposure history, communicable diseases, and other clinically relevant information. These are all variables. Though it's a note for explanatory note, it's not included. These variables are not included in your pre-examination documentation in the quality manual. Financial information for billing purposes varies from person to person, varies from group to group. Financial audit. Resource management. What are the resource management? 8 resources. What are those 8 resources? Manpower, human power also, management, material, method. These are the first 4 basic, and the mechanism, like process flow chart, etc. Then 2E, environment and equipment. Next, last one, information. There are totally 8 resources. Management and resources management. How do we manage these resources? If there might be shortage of resources, maybe more usage of resources, and utilization review, which is missing in most of the lab. Energy audit is not done. Water audit is not done. We do what is called internal audit. We do auditing of processes and which it is collected. This then last two under the request form information. This is the 20th variable. Date and where relevant, time of primary sample collection. Date and where relevant, not for all examinations. Assessors cannot demand that you have not put the time of the sample collection. Is it not? It may be irrelevant. Date and time of sample receipt, there it is required for the calculation of turnaround time. The format of the request form. What is request form? Examination request form. Don't say test request form. Electronic or paper, and the manner in which requests are to be communicated to the laboratory should be determined in discussion with the users of laboratory services. Who are the users of laboratory services? The examination request form should be prepared in consultation with the user, which is not normally done. You go to any laboratory, ask who prepared this examination request form, which you were calling it a test request form. They say, we prepared. We sat one day and we prepared. Did any clinician approve this? No. It is for the clinician, but we prepared. But unless clinician approves, user approves, it cannot be considered as a valid examination request form. Please see, this consulting, taking their opinion, minimizes the variability, increases the dependability, accuracy of the examination request form. Okay, the laboratory shall be willing to cooperate with users or their representatives in clarifying users' requirements. Coming to another variable, which we have something like in the primary sample collection and handling, there are only instructions. Till now, we had information. There's a difference between information and instruction. Information is validated. Instructions are modified from time to time. Instructions are one-time instruction, whereas information, multiple use information. Remember that up to 5.4.3, it's all for multiple use, and variables are very important. Now onwards, let us look at the variables from primary sample collection and handling. Under this, we have pre-collection activity, we have collection activity, we have sample transportation, sample reception. All are pre-examination processes. The laboratory shall have documented. Again, in this is only clause other than 5.3. This is the only clause. There are more than one general. 5.4.3.1 is general. 5.4.4.1 is again general. Now, the laboratory shall have documented procedure for the proper collection and handling of primary sample. Here, collection and handling. Collection may be by any method, by disposable syringe and needle, maybe by the finger prick for capillary, for mixed blood like capillary, the arterial and venous blood, maybe cisternal puncture, maybe the arterial puncture, maybe venous puncture, whatever it is. Handling. Handling becomes another variable here. Therefore, collection is a variable. We may use vacuum tube. Some people use the vacuum, the disposable syringe and needle, take the vacuum tube, remove the cap and put the sample into that. This also I have seen. These are all what is called violation of the existing variabilities of the pre-sample collection phase. The documented procedure shall be available to those responsible for primary sample collection at the anatomical collection and anatomical site, in the phlebotomy area, in the wards, whether or not the collectors or laboratory staff. There are a lot of variables amongst the expertise, competence of people who are collecting samples. That can also lead to variability in the examination results, where the user requires deviation and exclusion from or addition to the documented collection procedure. These shall be recorded, included in all documents containing examination results, not the test result. I'll tell you, most of the laboratories They say end of test report, end of test report. Where is test? End of examination report. If they write end of report, it's incomplete. It should be end of examination report. That is more focused. I am sure there's a lot of take-home message today to most of us and shall be communicated to the appropriate personnel. If it is communicated inappropriate personnel, more variability, more defect in the validation. Because I told you, one of the important validation processes for your end examination result is the pre-examination phase. Note here says all procedures carried out on a patient need informed consent of the patient because of legal requirement. For most routine laboratory procedure, consent can be inferred when the patient presents himself or herself to a laboratory with a request form and willingly submits to the usual collecting procedure. For example, vinipuncture is routine. Something. Example, patients in a hospital bed should normally be given the opportunity to refuse. Otherwise, if they don't want to give sample, if forcibly sample is collected, there are hormonal disturbances, there are emotional disturbances. You know very well that some parameters may vary. Therefore, this is again, and also there are ethical issues there. Coming to special procedures, including more invasive procedure, I told you paracentesis, thoracentesis, etc., with an increased risk of complications to the procedure, will need a more detailed examination by concerned expert. In some cases, written consent, informed consent. In emergency situation, somebody comes, is brought in comatose condition, some neighbor, they don't know who it is, somebody is lying on the road, they bring, consent might not be possible because no Aadhaar card, no indicate where, from which country that patient has come. Under these circumstances, it is acceptable to carry out necessary procedures, examinations, provided they are in the interest of the patient, they are in the patient's best interest, not for publication purpose, please remember. Therefore, this is another variable which we need to see under pre-examination processes. Adequate privacy during reception and sampling should be available and appropriate to the type of information being requested and primary sample being collected. Coming to instructions for pre-collection activities, there are 5 of them. A, B, C, D, E. Okay. Laboratory's instructions for pre-collection activities shall include the following. These are all variables. Completion of request form or electronic request, there is a variability. Uncertainty. When I talk about uncertainty, not only measurement of uncertainty, which is 1.96 multiplied by 2. CV is not that. Here there's an uncertainty of documentation, preparation of the patient, instructions to caregivers, to prepare the patient at home, fasting, without drug, after drug, cessation of drug, phlebotomists should be given instruction, sample collectors and patients' instructions should be specific. There could be a lot of variability here. That causes some error at the end result. That could be avoided. Type and amount of primary sample to be collected with description of the primary sample container and any necessary additives. Otherwise, they'll be thrown, they'll be washed. As I told you some time ago, clinical is special timings of collection where needed for malarial parasite evening and for steroids 8 a.m., 8 p.m. for chronobiologically influenced analytes or parameters, appropriate time should be collected. Some analytes can be collected at the middle of the night when the ACTH level is the lowest. Clinical information relevant to or affecting sample collection, examination performance or results is another variable. This is something which varies from department to department, section to section. It also needs a lot of investigation about patients' drug history and things like that. Let me check. These are the 5 instructions for pre-collection activities. They are all variables. Now coming to the instruction for collection activities. There are 8 variables here. What are they? The laboratory's instruction for collection activity shall include the following: A, B, 1, 2, 3, 4, 5, 6, 7, 8. H up to H. Now let us see determination of the identity of the patient from whom primary sample is collected. There could be variability here because there are, I went to UAE, there were 5 Mohammeds. And which Mohammed patient sample? John in Tamil Nadu, maybe Joseph in Kerala, maybe Murthy or Ram in Andhra, maybe Iyer or Iyengar in Karnataka. Now, there are so many. How do we identify the patient from whom primary sample is collected? That unique identification which has come, there could be a variability here which can lead to erroneous reporting, means wrong reporting. A verification of the patient means pre-examination requirement. Double checking is required here because this is another factor which can misguide the interpreter of the examination results, like time of last dose of medication, cessation, sample collection, predetermined time or time intervals, etc. Now coming to the third one variable under instructions for collection activity, instructions for collection of primary blood and non-blood samples. We talk about phlebotomy, we don't talk about non-phlebotomy. With description of the primary sample container and any necessary additives, because for every blood sample collected, there are 5 non-blood samples collected in some of the advanced testing laboratory. I tell you, for in next generation sequence, they take some saliva, they go ahead with that. If you go to molecular diagnostics, except blood, every other sample is collected. Tissue is collected, nail is collected, hair is collected. Now, one has to know instructions for collection of these samples. There are a lot of variables associated with that. The fourth one, in situations where the primary sample is collected as part of clinical practice routine, information and instructions regarding primary sample container, any necessary additives, you see, and any necessary processing and sample transport condition shall be determined and communicated to the appropriate clinical staff. They should know. It is invariably not told, not given to them. I tell you, sometimes I become a very unwanted assessor for assessment because I probe into all this. And it creates a lot of embarrassment for my friends, my colleagues, my students. They say, sir, please don't ask all this. These variables can have an influence on the end result, can lead to risk. Risk avoidance, I tell you, is also, this is one of the factors. Instructions for labeling of primary samples in a manner that provides unequivocal link with the patient from whom they are collected in case the additional samples are required. This is another variable. If it is not done properly, then samples cannot be collected. Then sixth one, regarding the identity of the person collecting the sample and the collection date, and when needed, recording of the collection time. The person who collects the sample has a barcode on her chest or his chest. They swipe it to the barcode reader. All the data is captured. Now, this is they read the barcode of the tube, barcode on their chest, and barcode at the reception, and barcode on the instrument. There is a traceability, trackability. If that is not there, difficult to track, then it may lead to additional variabilities which will interfere with the interpretation of the exam results, especially in tissue histopathology. Instructions for proper storage conditions before collected samples are delivered to the laboratory, which is lacking in most of the collection centers. Collection centers are not equipped with air conditioning. Collection centers are not equipped with controlled environmental conditions. Finally, safe disposal of materials used in the collection, if they are not disposed, can have influence on subsequent collections, because the infected samples, if they're lying in the collection area, sample extraction area, I would like to use the terminology. So instead of sample collection room, it should be sample extraction room. It's not just collection. From courier boy we collect, but sample extraction area. Otherwise, it should be called primary sample collection room, not just sample collection room. Please remember this. These are all some terminologies which we need to use. Coming to the sample transportation, there are 3 variables here, A, B, C. What are these 3 variables? The laboratory's instructions for post-collection activities. See, when you see pre-examination processes, it has 3 parts, as we have seen. Pre-sample collection process, before sample is collected, sample collection process, then post-sample collection process. This one comes under the post-sample collection process. Post-collection activity shall include packaging of samples for transportation. This packaging material, packaging technology, packaging the adequate, with environmental condition plays a very important role. The laboratory here, the laboratory, maybe Aparna's laboratory, Dr. Venkatesh, or Santwana's laboratory, shall have a documented procedure for monitoring the transport. See how many documented procedures are required in the pre-examination processes already for monitoring the transportations of samples to ensure they are transported And within a time frame appropriate to the nature of the requested examination and the laboratory discipline concerned to preserve the measure end. What is that measure end? Blood sample for glucose. Measure end is the property of the glucose in that blood sample. That is the reducing property. That reducing property is used to develop that method, GOD, POD, or hexokinase. The property of the analyte, the property of the material which you are estimating by using a method is called measure end. That should be preserved within a temperature interval specified for sample collection, handling, and with the design and designated preservative to ensure the integrity of samples. C says the sample is transported in a manner that ensures the integrity of the sample and the safety for the carrier, general public, and the receiving laboratory in compliance with established requirement. What is that requirement from? Where do we get? That is the national guidelines are there. Not only biomedical waste handling is a biomedical material handling. You go to ICMR website, find out transportation conditions and variabilities associated with that. You will get plenty. Though I have mentioned here only 3 of them, there are more than 35 variables under sample transportation. Whether you should use global courier, whether you should dry ice, whether you should use pre-chilled gel, etc. A laboratory which is not involved in primary sample collection. This is the excuse we are all taking. We are not involved in sample collection. We are not involved in sample transportation. He is considered, even they, with whom, from where you are getting the sample, from where the sample is transported, they have, your laboratory is considered to have satisfied this clause, 5.4.5C, the manner that ensures integrity of the sample and safety of the carrier. If today, if you order food through Figgy and if it comes late, even in the cold, they will return it. Will laboratory return that if they are not properly collected, transported? Whose integrity was compromised or which could have jeopardized the safety of the carrier or the general public? The sender is contacted immediately and informed about measures to be taken to eliminate recurrence. No, it can happen once. Should not have subsequent time. This is another variable with reference to the sample, integrity of the sample, like the preserving the measurement of that sample prior to the analysis. This is a very, very important requirement. This is about the sample transportation, 3 variables. These are the 3 variables, A, B, C. Coming to sample reception. Okay, sample has been, all the previous conditions are 100% met in an imaginary lab. Very difficult to say that we have met all this. Harvard publication has stressed, if they find the pre-examination processes complying with the standard 100%, they will give an award to such a laboratory. It is not easy because in a laboratory, medical diagnostic laboratory, in the pre-examination phase, total number of minimum 42 people are involved. Right from the person who collects money and draws a receipt till the boy which delivers, courier boy, report to the concerned end user. Now, for the pre-collection, for this pre-sample reception, laboratory procedures for sample reception shall ensure that the following conditions are met. Therefore, there should be a procedure. It doesn't say documented procedure. Now, some procedures are practiced. Now, samples are unequivocally traceable by request and labeling to an identified patient or a site for any additional information, additional sample, etc. There is a variability here. This is one variable. There are total 6 variables here under sample reception. Second variable is laboratory might have developed and documented criteria set of rules for acceptance or rejection of samples, which has to be applied. That may not be applied 100% because patient has already paid the money. Sample cannot be rejected. They process it. If they reject, they have to refund money. The system does not exist to refund money. There are so many other inherent problems. Then where there are problems with patient or sample identification. Sample instability due to delay in transport, or inappropriate container or containers, insufficient sample volume, like for CSF from a child, or when the sample is clinically, critically, or irreplaceable, and the laboratory chooses to process the sample with a what is called a buffer, some kind of a, and the final report, examination report, not test report, okay, shall indicate the nature of required of the problem, and where applicable, that caution is required when interpreting the results. Here you can imagine, underline, note how many variables are there in this particular C of 5.4.6. There are 8 variables within that. Now, D, all samples received, whether in-house collected, outsourced samples, or through collection centers, are recorded in accession book and worksheet, which should be audited every day, end of the day, or in between at some time, or maybe on the computer or other compatible system. It needs to be audited to eliminate variables in this, the wrong entries by right type of person. Person may not be trackable for wrong entries. All this can happen. The date and time of receipt, date and time of registration of sample shall be recorded. Shall is a mandatory requirement, where whenever possible, the identity of the person receiving the sample also should be recorded at the reception. The person who should have rejected has not rejected, should have accepted but did not accept. So several things can happen. Only authorized personnel, they should be in writing by the superior, shall only evaluate received samples to ensure that they meet the acceptance criteria. That record shall be maintained, relevant for the requested examination or examinations. This is another variable. A, B, C, D, E, F, and G are also there. Now, A, B, C, D, E, F. Okay. Whenever, where relevant, there shall be instructions for the receipt of samples, labeling of sample, processing of sample, reporting of these samples, specifically marked as stat, urgent. Is there, if it is not done, this is a variable, it is urgent requirement. That's why it requires urgent. If it is not done, then where is it? We have not validated the examination results. Look, examination result, it does not depend upon only the ensuring the quality of examination results, that is 5.6. It also depends upon 5.4.6, not only 5.6. Why I'm telling you, remove this 4 and you are left with 5.6. That is the validation. What internal quality control or quality control, external quality assessment, etc. That is the validation. But more validation is there in the pre-examination processes under 5.4.6. The instruction shall include details of any special labeling or the request form and sample, the mechanism of transfer of the sample to the examination area of the laboratory, any rapid processing mode to be used, and any special reporting criteria to be followed. All that has to be documented and should be adhered to in the pre-examination processes. Where at the time of sample collection, these are for special care. And all portions of the primary sample shall be unequivocally traceable to the original primary sample before discarding. 5.7, post-examination processes, samples are retained just only for discarding, not for retesting and re-examination. It is only for the ethical requirement, legal requirement. Samples are stored, samples are discarded under 5.7 post-examination processes. One more thing, results are validated looking at pre-examination requirements and ensuring the quality of examination results, that is 5.6. Under 5.7, 2 clauses are again reviewed. One of them is 5.4, another is 5.6. Remember this. Coming to the pre-examination handling, preparation, and storage. Okay, at the reception, samples are being received. Your laboratory shall have procedures. your laboratory will have appropriate facilities for securing patient samples and avoiding deterioration. Securing, what does it mean, securing? For many requirements. It should be preserved at appropriate condition, should be protected from unnecessary, unwanted access by unauthorized people because of confidentiality. Securing, security. I have seen in laboratory sample security chamber. I was wondering what is the security? Is that security to the sample? I asked, is it from the Prime Minister or the President? No, sir. We have security for all samples, not only for VVIPs. Security here refers to protecting the sample's integrity and its measurement, and also seeing that avoiding any deterioration, especially for samples which are transported across the continents. Samples are coming from Dubai to Bombay, Bombay to Dubai. So many things are happening. Samples from India are going to Persia. I was assessing one laboratory. I was surprised to see on particular day so many samples came for Lyme disease. Lyme disease detection. So many samples came for NGS, next generation sequencing for a family, some members had sent samples. Therefore, deterioration should be avoided, or loss should be prevented. Damage should be avoided during pre-examination activities and during handling, preparation, and storage. Handling, preparation, and storage are three variables here. And laboratory procedures, whether pathology, microbiology, biochemistry, there are so many procedures, shall include time limits for requesting additional examinations. That means for re-exam, repeat exam, it comes under 5.4 in the pre-examination process, not under 5.5 or 5.6. Not in the examination processes or in the post-examination processes 5.7. For anybody who wants any examination, it is considered as a pre-examination request. I have sent sample to you. I wanted 8 different tests. You have done all the 8 tests. I want 9th test. When I request for the 9th test, sample is in the laboratory already, but still my request 9th test is considered as pre-examination process. Very clearly mentioned in this. Time limits for requesting additional examinations, that depends upon the stability of the sample. That depends upon the availability of the expert. That depends upon the availability of the resources in the laboratory. Some samples for some tests are sent to another laboratory, referral laboratory or B2B, but still all these facilities available for the 8th, 9th sample, which 9th examination requested. This is again another variable. Okay, I will stop sharing. Now let us have a discussion. Over to you, Santwana.
Thank you so much, sir, for such a wonderful session. In fact, I thought maybe it can continue for another 15-20 minutes before we could start asking you questions, because there's a lot of information that you have shared with us today. A lot of vital information, which we had a lot of missing links. And there were a lot of queries in our mind, which actually you have cleared even before you would ask the questions. So there is one question, sir, from one of the participants, who is saying that in case of a test requisition form or a
examination request form.
Yes, that's what I was just coming to. What they call as the test request form, which is actually an examination request form. It is not possible for the laboratories, the large laboratories, to have the discussion with all the clinicians, because every clinician has their own thought process. So can they come to some kind of a consensus and have one single examination form made, which may differ from the requirements of every clinician?
Beautiful. Very good question. Who is that who asked this question?
I got the message on my
Very
WhatsApp.
good, very good. I tell you, the container is not important, content is important. When I say container, it is the forum. Content is the information. In the pre-examination processes, it is the information. Information can be in one site or in multiple sites. For a small and medium laboratory, it could be at one site. Maybe a large laboratory with 10 different laboratory systems, they may have different. Now, all clinicians who are sending sample need not vet that. One or two representatives come to your birthday, says, enjoys the cake and approves, okay, this examination request form is fine. That's enough. Therefore, it is again laboratory policy, comfort, but information is more important than the form. Container is not important, content is important.
Okay, sir. Thank you so much.
Santwana, can I just add to that?
Yes,
Sure,
please,
sure.
Dr. Seema, please go ahead.
Yes, sir. So just one thing is that what is important, as you said, the content is important, and you have to take that content from those people in whose patients it makes a difference. The content makes a difference. For example, you talk about pre-surgical. You need to know what is happening to the patient and therefore what do they require in that. Or for example, when you have a patient of hepatitis, is there something specific they want? Nowadays, lipid profile is done non-fasting, so it doesn't matter at all. So these are the little things you try and pick up the nuances from each and every. You can even, what we often do is we talk to each of the HODs and say, is there anything more you require that we need to show here? And they
Absolutely. Earlier we used to have
tell us.
CPC, you know. Now these days we don't have CPC.
Oh,
Clinico-pathological.
So they still tell us. They still tell us. They're very nice, and
Excellent,
I think they
excellent.
give us those few minutes and they tell us. So sometimes
100% I endorse your views, Dr. Seema. Very well
thank you,
said.
sir. So that's all I just wanted to add to that.
So, Dr. Seema ma'am, that definitely in your case, it's an institution. This message that I've received is from a large laboratory. So I understand that they should work upon in consensus with the clinicians who are there in the area.
Yeah, I guess, see, actually, because we're a hospital-based lab, it becomes easier for us because most of our clinicians are there and we just pick up the phone and call them. You know, even if we don't get the top person, we get the next person. But for a standalone lab, it is next to impossible to be able to ask everyone. As Sir said, he very clearly said, you know, you have to have some representatives who are knowledgeable enough and you ask them, okay, what else do you think we need in this?
You see,
Sir,
Dr. Seema.
very beautifully.
Dr. Seema.
Yes, sir.
The standard ISO 15189 has very clearly mentioned any of these requirements are not appropriate for standalone lab.
Yes.
Very clearly it's mentioned. Under 4.1 itself, in the beginning itself, under the management requirement, it says many of them may not be appropriate for the standalone lab. It's appropriate only for the hospital attached labs.
Sir, I hope there are many assessors sitting in this audience. They need to know it. So you have really pointed out such an important thing.
It's there in the standard, I tell you.
Yes, sir. Thank you,
Thank
sir.
you, Dr. Seema, for bringing out this wonderful thing.
So there's a question from Dr. Zubair. Sir, what are your views on variabilities in home collection?
Variability in home collection is the first number one, time. Time is a variable factor, number one. They are supposed to collect at 7 o'clock, they go at 9 o'clock. Poor old man is fasting from yesterday morning. One variable. Second variable is whatever we have covered under this sample collection, both request form information, 7 of them, information to patients, and that is 15 of them, collection and handling part, all these things are variables which has to be considered by the phlebotomist who goes to collect samples. I tell you, who are these phlebotomists? I will tell you, they are not BSc MLT or DMLT. So they are some of the certificate course. They know how to collect samples. That's all. They become not technicians. They become skilled workers to go and collect. Today in Bangalore, for throat swab collection for the RT-PCR, they have not even passed SSLC. What qualifications required to put that swab and rotate it and pull it out and put it in the tube? If you see home collection, these people need training. That's why there is a proposal to the government of India, it's almost through, phlebotomist certification program under Skill Development Council. Very good question you asked me, Dr. Aparna. This is a gray area. We need to, all of us need to put our head together with thoughts, then get it done. There are a lot of variables here. One Deshpande wanted sample to be collected. Phlebotomist went, said, Deshpande sample I have come to collect. Deshpande was having birth. His wife is also Deshpande. She gave the sample. He brought it for prostatic specific antigen. Imagine some mishap can happen. If there's, these are all variables. Proper training, proper education, if it is provided, this can be avoided. Where is prostate to Mrs. Deshpande? Tell me. Many such things have happened. It's happening. It goes unreported because of punitive action, fear of punitive action. Any mistake should be non-punitive, even in the medical laboratory diagnosis. Okay.
So there's a question on hospital-based sample collection variables. We train the nursing staff, but still there are a lot of variables in that. So
Yes.
What is your suggestion on the same, sir?
You see, the sample collector, wherever the sample collection person is, whether in the collection center, in the hospital, it is the responsibility of the laboratory to guide them, educate them. If they do it, there should not be any difference between the laboratory sample collector and the hospital nurse collecting sample. That certificate should be available in the nurse's personal file that they are trained by the laboratory to collect sample. Then variables can be minimized. Because it is again department-wise, section-wise. I am not an expert in your area of discipline, therefore, I will. That's why I took only standard as my guide. I have just restricted my talk on variables for the pre-exam with reference to standard, because every one of you are using the standard to get your laboratory test methodology accredited.
So, if you may permit, may I add on to this query?
Yes, Dr. Ashwini, please.
Yeah, sir, basically the nursing counts the collected samples. There are a lot of variables that we do tend to see in hospital-based samples, because they don't collect from the peripheral lines. They collect from the central lines.
Absolutely, absolutely, Ashwini, I agree with you. Shankar also told me, I hope you, both of you must have shared this information. I tell you, Ashwini, this is something where laboratory has to take the responsibility, not that nurse. We have failed to train that nurse.
No, sir, that is what, there are continuous training sessions. That is exactly like, sir, what you said, training of the nursing, which should be taken from time to time, not only regarding the collection processes, but also what do's and don'ts are necessary in central line collections. And also that our sample collection manual and the procedures should be available to the nursing from time to time, so that they know what sample has to be collected in what. And secondly, the most important aspect I feel where they also tend to make mistakes is that the coagulation, because coagulation profiles and the sample collection, if there is wrong, then it does give a lot of erroneous results. So a little careful collection is what is necessary. That's all I wanted to add on, sir.
Yeah, very good. Ashwini, I appreciate it. Thank you very much for this input. I tell you, last month, I was in Persia on behalf of IAS, International Accreditation Services, assessing a laboratory. That laboratory works 24 hours. As an assessor, what I did, I went at 2 o'clock in the night. Normally, we do the assessment during 8 to 9, 8 to 8 or 8 to 7, whatever it is. I went there without telling them. I went to the laboratory at 2 or 2:30 in the night, because I was staying in the premises only. I walked in. And they were waiting for sample to come from one of the wards, hospital attendant. I said, can I go there? I went there. I found that nurse from some country, I tell you, Filipino nurse, collecting the sample. And I watched and I came back. I asked next day morning, the laboratory director, have you done competence evaluation for all your staff? The director said, of course, we have done twice, thrice after every training. I would like to see the competence assessment of one of your sample collectors who is in the ward 3B on the second floor of gynec department. I said, who? We have not posted anybody. I said, on your behalf, one nurse is collecting sample. Last night she collected. I found that she did not know how some of A, B, C, D. I noted down. Have we done the competence evaluation of these people whom we have trained? We have to introspect.
Absolutely right, sir. Absolutely right, sir. This should be done from time to time.
My message to for all of you to take home. When you go for assessment, my dear assessors, most of you I train. Some of them up late, I'm not training. Please go in the middle of the night, do assessment of the laboratory performance. Like in the hospitals, we do in the middle of the night when no clinician is available. That will give you the true picture. Never use the lift, use the staircase to find how many are sleeping, security on the staircase. Okay.
Sir, I'll just add on to this is that in our previous organization where I was working, we have done this as one of the induction program. One of the topics in the induction program was on phlebotomy for all the nursing staff. And at the same time, there was a quarterly training session for all the nurses, wherein it is a repetition and it helps them with improving their knowledge if they have missed out on something, and with some examples which are actually taken from the hospital itself. So it prevents them from going ahead, doing mistakes in future. So there's one suggestion from Naveen Kumar Sivakumar, who says vacutainer and instrument manufacturers can come together and reduce the volume of sample collection required for individual tests. Or why not we use pediatric vials for single test? This will help in reducing the BMW generator.
I agree with this suggestion. I tell you, when you talked about induction program, personal introduction to the organizational environment, in induction program, what they normally cover is the conditions of employment, staff facilities, health and safety requirement, including fire and emergency only, and occupational health services, but they don't cover the other part of training. Under the training, there are something like 6 training in the quality management system, training related to assigned work processes to them. That is where the phlebotomy training comes. After the training, there should be competence evaluation. This is very important. In addition to that, where applicable, laboratory information system training, again competence evaluation there, and training in health and safety, training in ethics, training in confidentiality maintenance. These are the 6 training which is required to all the people, including nurse who attend, does some part of the laboratory work.
Yes, sir. And I think taking your this Santwana, that other, I think we need to work on this, that there is a lot of sample wastage in vacutainers, especially in coagulation, where there is such a lot of sample that is collected and there's hardly one test that is done in that. So yes, I think we need to work on this.
Yes, Dr. Ashwini. Yes, Dr. Ashwini, I tell you, during 1968 and 70, 71, when I started my career as a tutor, we used to do blood glucose by that Folin-Wu method, where we required large volume. We used to collect about 5 ml and 4.5 ml we used. But today we collect 2 ml and we use only 20 microliters, 10 microliters.
Yes, sir.
You are right, Ashwini. The way in which we have not changed our methodology. We have changed technology, but we have not changed ourselves. Technology should be economical by reducing cost, reducing the resources. In fact, patient sample is a very powerful resource. We cannot afford to put it in the drain. If it is infectious, the whole community gets infected, you know.
Thank you so much, sir, and thank you, Naveen Kumar Sivakumar, for this wonderful piece of advice. And yes, we all over here would definitely work under the kind guidance of Dr. Venkatesh and put it forward for you all. There's a question from Dr. Saurav Mathi, and I would request Dr. Saurav Mathi to please ask.
So there is always a confusion between the serum and the plasma samples. So I think the lab should have the policy of this, but how we can ensure that the technician
Very good
understands
question.
it?
Very good question. See, the IVD manufacturers in the examination procedure, what they have provided, they would have specified whether you should use plasma, whether you should serum. Stick to that. Don't deviate. Number two, for some analytes, we have to use the whole blood. We cannot use serum or plasma. For example, Santwana introduced me as the lead man of India. I estimate blood lead level. I need whole blood. Lead is not in the plasma or serum. It is inside RBC. We have to take out that by lysing it under hydrochloric acid and then estimate. Now, some of the researchers have used serum for the blood lead level, arrived at some conclusion. Then I told them only less than 0.1, less than 1% of lead may be in the serum, maybe not there. Therefore, plasma, serum, whole blood, we must adhere to the instructions provided by the manufacturer of the methodology which we are using. Very nice question, Saurav. Let us not deviate from what we are guided to do. Okay?
Thank you, sir.
Thank you. So there's a question from Malika
I saw
Kawachia.
that. How do we collect samples in a patient who has IV line in both the arms? Wait. And it depends upon which analyte you are looking for. If you are looking for electrolytes and there's an electrolyte infusion, don't collect it from that. If you're looking for glucose, don't collect it from the other arm. Or arrest that IV line for some time, let it stabilize and then collect. Because we have to get into the homeostasis of that particular sample. It's always better to collect it from left hand, which is closer to our heart, where the stabilization takes place much faster.
So there is
I may not be an expert on that. Maybe Aparna, you please add from your expertise, your knowledge.
So I think what you are saying is absolutely right. In fact, there is a very good question which I do face, but that's why I asked Santwana to ask you that what do we do if IV lines are there on both the arms, and that does happen in an ICU patient. Then what we do is we take femoral. I mean, we have taken it couple of times when both the hands are fired or both the hands have IV lines. So I think in JJ hospital we have always been trained to do femoral. So
Thank you, Aparna.
Apart from femoral, there is
Yeah, that can be done, but it all depends upon what analyte we are looking for.
correct.
The central line collection also, there is a mechanism of taking.
Yeah, there is.
So we have to discard the first 5 ml of the central line sample, and
God.
then that is another way of taking samples.
But Ashwini, there is very less compliance.
Yeah.
When you're doing that, it's not so easy in private sector. So I have then requested sisters to help us because we are confident in doing. If there is 15-20 ml of sample needed, as Dr. Venkatesh is asking, then that's the last rescue which I have done. But if there are any other suggestions, yeah, they are welcome.
The best way, which is much easier, is like arresting the IV line for some time and then taking the sample if it is not something wherein a life saving drug is being continued for a patient.
But sometimes what happens when they're infusing some drugs, then we cannot disconnect,
Santwana,
Yes, that's what I'm
there are
saying.
several conditions. It is
Most
better
of these
to
patients
consult
are
the
all ICU
clinician and then
patients.
go ahead with the procedure.
Yes,
That's
ma'am.
not possible. In ICU, they are
Yes.
they are on cardiotropic drugs. One side they are on diuretic.
Yes.
You
Yes,
can't stop it.
that's the reason why I said if they are not on any life-saving drugs and if it can be kept arrested for some time, then definitely
That's only in the
one of the-
consultation, the clinician, it has to be done.
And
Yes.
most important, as I think both of you are talking, that we have to train nurses. If we are not actually trained our technical staff, the sample will come, they will run, okay, my God, potassium 9, 7, and you don't know what. And if the report is interfaced, you're gone. I mean, that is your failure. And that's where we keep on training. sending WhatsApp messages in the groups that
Dr. Ravi Kumar can throw some light on this particular thing.
Hello, sir.
Ravi, please
What is
throw
the
some light
question?
on this.
What is the question, sir?
Question is, when patient is on IV and both the arms, if we have to collect some sample for some analyte, how do we go about?
As you said, depends on the what
Analyte.
sample. Yeah, what analysis you are going to do it.
That's what I also thought.
Yeah, and is not advisable for almost for 2 to 3 hours
Yes.
till the homeostasis is
Correct. Absolutely.
stabilized.
This is what I also thought.
That's what I feel.
But you are a better clinician. Therefore, your wisdom is more useful to all of us.
Yeah.
Thank
Sir,
you.
some of the books, sorry to interrupt, sir, some of the books say that what you can do is you stop the line for a few seconds, and from the pedal end of the line, you withdraw sample about 1 ml to 1.5 ml, you discard that because that will be only the drip that is going in.
Yes,
and
yes, yes.
or an admixture of blood in the drip. And then after that, the sample that you draw is what you are sending for analysis.
Yes.
That has been the suggestion in the books.
Thank you, Seema. Thank you for this.
You're welcome, sir.
Wonderful inputs.
I would especially like to thank Dr. Venkatesh for being with us today. It is such an honor. And what he started with was how the how 4.1 is a clause that is not supposed to really affect your to some extent is not supposed to affect your quality of results, but he showed how the attitudes at that point, how the attitudes of how you conduct your training and how you assess your employees, how that affects your results. And that is so important, that quality percolates from the top down. And we must have the best. Thank you so much, sir, for emphasizing that. Apart from that, I'd also like to thank Kaho for giving us this opportunity here, and all the participants, all the panelists. It is so nice to have all of you on board and to have such an interactive session. Over to you, Dr. Ravi.
It was an excellent session, madam. For all the participants, Dr. Venkatesh Thuppil, a legend in our, we are all very fortunate to have such a type of person as a leader. And I must thank on behalf of Kaho to Dr. Venkatesh Thuppil, sir. Sir, we should have more sessions from you here onwards, sir, so that we can extend your knowledge for all of us. Thank you very much, sir.
Ravi, I'm always there.
Thank everybody.
Ravi, I'm always there with you.
Yes.
As the patron of Kaho, what better I can do? I should do this. For every section in ISO 15118, and we can keep 1 or 2 hours of discussion.
Yes, sir. Yes, sir.
That is what is guiding us. I'm just waiting for 1st November 2022, that new version come. And I'll be the first person to come and stand and interpret, because I've already prepared the PowerPoint for that. We'll definitely do that. Thank you, Ravi. Thank you very much.
Yes, sir. Thank you very much, sir. Thank you.
Thank you so much.